discussion. It was a laparoscopic cholecystectomy, what looked like a very simple gallbladder, and then we'll pause the video in between for questions. Niranjan, please feel free to interject anytime you want to, so because your inputs will be very vital. This is not it's taken from the YouTube, so it is not any gallbladder that any one of us have done or anybody that we know of. It is taken from YouTube. Okay.
I'll start the video, sir.
Yeah. Make it full screen. So this is important. Okay. So that statement that they have done made under the surgical resident under direct supervision of a trained surgeon. Okay, carry on. Pause here, pause here. Okay. Now, can anyone comment at this stage itself? Is there anything wrong?
Sir, the CBD is getting pulled up so high. Like he is giving traction, and we can very well see the CBD which is getting tented up.
Nitya, even before that, is there anything
Yeah.
like not routine about
Third,
this?
fourth port is not there, sir.
Yeah.
That is
So they are
one.
trying to do a three-port lap chole, that too
Yes,
by
sir.
a resident. Okay. And
Okay.
why do you think that has happened, the tenting? It is because you are giving more traction because you
Traction.
don't have a fourth port at the heart punch.
Correct.
Yes.
And that's
Niranjan,
why the CBD is
other thing
being
is
lifted up.
there is no, they are not picking up the fundus of the gallbladder. If they had picked up the fundus of the gallbladder, you would have seen the heart pump better. Here they have, because they don't have the other port, they have, picked it up. And as you said, they are getting up the CBD. Okay, carry on.
Sir,
No,
here can we
dissection
make
should
out this?
start at the junction of gallbladder and cystic duct.
Correct, Srikanth. See, Srikanth, good evening. Welcome for the swim class. Basically, they are doing it with three ports with the resident, and
That is wrong. Resident should start conventionally, not three ports.
I
That's the
think
first.
even a very experienced surgeon, I don't see the reason why you should do it with three ports. If at all you want to do it with three ports, what Ramesh, AV Ramesh had suggested, or somebody else also, is to put a stitch at the fundus and use that to lift it up, and that will be there till the end. When you want to let go of the gallbladder, you can just take the stitch off. So if you want to avoid a fourth port, which I don't see any advantage in, you have to do that. But you can't compromise the safety because you want to do it with three ports. Okay, carry on.
Sir, can we make out any sulcus in this image, sir? Is this the sulcus or?
No, it is all wrong. There is you can't if you are holding.
Whatever you're pointing out, that is probably the Rouvier circus. It is just at the junction of cystic duct and
It
CBD
is
there.
not always present.
Okay, sir.
But that is not always the correct landmark. But in this case, that looks like a Rouvier sulcus, and it is in the correct point there, cystic duct and the CBD junction there.
Okay.
Okay, carry on.
Any tubular structure, you first say, assume it as a common builder.
So we'll stop here again.
Yes.
See, the thing is, it is a, while you are operating, it is a healthy interaction between the surgeon and the assistant, whether it is the consultant who is assistant or the consultant who is the surgeon, it doesn't matter. But there should be a healthy discussion. I feel there is equal responsibility between the consultant surgeon who is training this trainee and the trainee also, because the trainee didn't stop and ask him, am I doing the right thing? And the consultant didn't stop him and say, you are not doing the right thing. Both of them are equally culpable in this case. Okay, carry on.
Never clip any structure as soon as you see. Think twice, thrice.
Yeah, see, go again, just go back a little.
All
Yeah,
beginners
see
get
here,
excited when you see a tubular structure,
see
thinking that
here,
is cystic duct. We have also gone through that.
yeah. What is wrong with this? Samir, let us start with you. Samir and Ainas, what is wrong here?
A critical view of safety, they have not ensured, sir, like
Where is the
fully.
cystic plate? A
Yes,
third
sir.
of the cystic plate has to be demonstrated, a
Yes,
minimum
sir.
of the third. And where is the posterior dissection?
The window is
That,
not
yes, sir.
done.
It's not done, sir.
There is no anterior and posterior dissection at all. They just mobilized something and they thought this is a cystic duct and clipped it. This cannot be accepted in any form or shape, because everything that they have done is wrong here. See, the thing is, you have to show that there is a gap between the liver and the gallbladder, right?
Yes, sir.
Yes, sir.
Yes, sir.
So
At least you have to lift the car for at least 25%.
so they have not shown the anterior and posterior dissection. They have just found a posterior, the plane between the tubular structure and the posterior aspect of it, and just they have clipped it without actually ascertaining what are they clipping. I think what Shrikant said is very right. If you see a tubular structure, don't think it is the CBD. If you remember, Sania, once you were operating one of my cases,
Yes, sir.
and you demonstrated a tubular structure, and you said,
That was for
shall we
cystic duct.
clip it, and shall we, I'm not sure, sir. So then I took over and we dissected a bit more. We found the
Yes, sir.
artery was humping, a common hepatic artery was humping over that, and then we found the cystic duct later.
Above it. Yes, sir. Yes, sir.
So the thing is, it is not wrong to mistake a tubular structure to cystic duct, because all of us can do that. But to just clip it in nonchalantly without thinking, without making it more obvious, if you are not sure, you do in the complete gallbladder dissection from its bed, but don't clip anything till you are absolutely certain. So that is the lesson. Okay, carry on the video.
Never clip without showing it to the consultant.
Correct. This he should have done a lot before, not now. Again, he is doing the same mistake. He is just dissecting
Blindly
the
clamping.
clipping. blindly clipping something without, and he's even using the cautery for this. Oh dear. See, I think Niranjan has taught you all as well. For example, in the posterior aspect, while you are dissecting behind the cystic duct, what have I taught you, Sanya? Never use what?
Sir, I didn't get your question, sir. Sorry.
While you are, just behind the duct, let us say you have demonstrated the duct. You are
Yes,
not,
sir.
there is a lot of tissue behind it. And when we are dissecting it, what have I told you?
Not to use diathermy, sir.
You not to use diathermy preferably, but if you have to use diathermy, what should you not use?
Monopolar, sir.
Hook, especially
Hook,
monopolar.
hook.
Monopolar in general, but hook especially, because hook is not hemostatic. See,
Yes,
the
sir.
problem is, if there is a big artery, let us say, even cystic artery may be very big, or it may be sometimes even either the left or the right branch of the hepatic artery behind it, because sometimes it can be there. So while you just blindly use if there is sudden gush of blood, the entire operation goes for a toss. Then in this one, to clip something, you will, maybe clip the CBD or something like that, or even the major hepatic artery. So that is why even when you have dissected the cystic duct and you think it is a cystic duct and you are going behind it now, use the bipolar or Maryland with the monopolar and gently dissect, and make sure that you are not using diathermy indiscreetly. Niranjan, your comments at this point, Srikanth?
Sir, same, sir. Until you are sure, you should never cut the structure there until you demonstrate the critical view of safety. If you are not able to demonstrate through regular dissection, you have to come through retrograde dissection and demonstrate.
Correct. Srikanth, anything
Yeah.
more to add?
Nothing. No, don't cauterize clumsily. Clearly define the structure and then do whatever you want.
Okay, continue the video, ma. See, this is very most dangerous maneuver. Without knowing what you are using the diathermy on, it's really such a dangerous thing. See, he has actually injured the bile duct there.
That is close to porta.
Very close to porta.
Difficult to. The duct will definitely go first, sir, even if you request.
So this is the lessons that he has said. What else would you like to add? Which we have already discussed, I think. Nitya?
Sir, always we have to achieve critical view of safety, sir. Even before clipping anything, we need to achieve critical view of safety, sir.
And this was a very and this was a very simple case where you could have achieved critical view of safety very easily.
Easily.
You got compromised to try to do a 3-port lap chole, which probably is of no use to anybody, and then you landed up in trouble in this case.
So that is the first lesson.
The
Don't
supervising consultant is totally guilty.
Yeah, absolutely. Don't do 3-port. Can anyone tell me what is the advantage of 3 ports?
No,
Anyone?
allowing the president to blindly clip and cautery.
And even if you are doing 3-port, your basic principles of surgery should remain the same, which is posterior dissection, anterior dissection, demonstrate critical view of safety, and then clip and cut.
Set off the gallbladder little from the bed, then clip.
I think the problem, Niranjan, as you said rightly, starting off with 3 ports, is where you hold the gallbladder is a very critical thing. See, surgery is, whether it is open surgery or laparoscopic surgery is as I keep telling you, I think all teachers have told you, is a balance between traction and counter traction. That counter traction is your dissection, use your diathermy, whatever, and the traction. So here you are applying traction at a very wrong point, and hence you started off in the wrong way. If you had applied traction at the right point, you wouldn't have landed up with this mistake at all. So if the fundus was lifted up and towards the right shoulder, it would have then given you the, the junction between the cystic duct and the CBD and the Hartmann's pouch. Then you would have started the dissection in the right way. But here, because you held it in the, in a very different angle, you thought that what you are dissecting is the cystic duct, but it was the CBD. So I think, as I said, both the resident and the supervisor are both guilty. Probably the guilt by, what shall we say, this one will have to go to the trainer, because it is his job to prevent something like this happening. Okay, carry on. There are still a lot of mistakes here in this video. So he's removed the clip now.
Sir, at this point of time, I had a doubt, sir.
Ah.
The bile was leaking from the probably a hepatic duct.
Yeah.
Like, should we do anything to stop it or control it, sir, or how?
No, you don't, because hopefully this is not a poison, cholangitis or anything like that. The bile was quite clean.
Correct, okay.
So you don't have to worry about the bile leak. From time to time, you wash it and suck out the bile.
Because that is the landmark. That is the landmark where you will be able to see what structure it is. If you close off or do something there without even skeletonizing it, just because bile is coming, you close it off. You never know what you're closing, or whether you're completely shutting it off, or you're narrowing the lumen. So never do that. Keep a gauze piece. If at all, if it is coming in your area, if bile continues to flow, keep a gauze piece down. Nothing will happen. Even if it is cholangitis, nothing will happen.
Yeah.
This is one of the hepatic ducts, whether it is sutures are allowed to leave, it will definitely go for structure.
So other thing I keep on telling you guys, see, the Asian Institute of Gastroenterology, Dr. P.V. Rao, Professor P.V. Rao.
Sorry to interrupt. Guru Shantapa sir has joined, sir.
Gurushantapa sir, welcome.
Namaskara.
You missed the juicy bits already.
Oh, okay, sorry.
Just go back and just show him quickly, ma. Sir, I'll tell you the background. So this laparoscopic cholecystectomy was being done by a resident under the direct supervision of a consultant, and for some reason they have chosen to do it by 3 ports, and see where they are holding the gallbladder. So this is the first mistake. See, the traction is in the wrong place.
Oh, the fundus is hanging because of 3 port.
Ade. So they are doing a 3-port procedure, and they are holding the gallbladder at the wrong place, and then he has dissected it without showing anterior and posteriorly, demonstrating. He has dissected this structure. Just watch, sir. I think it is. I am actually dumbstruck by the arrogance of both the surgeon and the resident.
I think surgeon should be blamed more than the resident.
Correct.
It looks like even a buried gallbladder. It is not a simple gallbladder actually.
Sir, note this. So this he has done this, and without doing anything. So now he is clipped it.
If it is for resident, why 3-port to begin with? Classical
Sir,
cholecystectomy, they should learn first.
no, but why, sir? Tell me the advantage of doing it 3 ports, sir.
Correct.
No advantage.
Exactly. Exactly.
Sir, just watch this, how they are doing the surgery with impunity, not worrying about anything. No, forget about after this, just watch what he does after this. Would you allow anyone to do this, sir?
Correct.
See this?
We teach critical view is only 2 tubular structures. You cannot go on
He
putting
doesn't
clips
even
and
know.
cut.
And look at that, sir. One clip is
Yeah.
applied to the artery,
Yes.
and then using diathermy is just see that. God, and he just keeps on going without knowing what is actually happening. And then suddenly see what has happened now. Look at that, sir.
Bapre.
So he has gone to the porta and without actually seeing what he is actually, and using the hook diathermy, he
Correct.
just burnt the bile duct.
Ravishankar, how did you get this video?
Sir, this Dr. Srimurthy sent it to me, sir.
Okay. Great.
On Teachers Day, I wished him. He said, please, present this video to your students and discuss it. So, as a true teacher, he has done that again for me.
But one more disadvantage of straightway students looking into these videos is there are few things. One, they get scared of doing the procedure because they have seen the complication. Second, their mind status, no, at this age, it is very difficult to understand what is not to be done at this phase of their life. So they should be seeing classical things in the beginning to while learning phase of their life. Classical.
Yes,
for that, they should be nowadays. For that, they should be lucky to get trained.
In our center, they were saying so many. I think they would have
they see
by
a
this
lot,
time.
sir, which is why
Okay.
and even second year resident does a full lab chole. So,
Excellent.
so that is why it's okay for them.
Okay, fine. More than they doing themselves, they should be seeing some good surgeries with a good surgeon as an assistant, as an observer. That really matters a lot.
Yes, sir. That they do they all listen, and even when they do, of course, we are always come till the procedure completely, even that we give the tab block and we make sure the tab block is given, only skin closure we move out. Otherwise, we are there all the time, all of us.
Excellent. Very good. See, still this gentleman is trying to show off by doing everything laparoscopically.
Correct. Now, he has done something that, that is why we have to show that mistakes don't end with the gallbladder, this one. Here, more mistakes are being conducted. So just watch this. He is trying to suture the bile duct in 2 places, and that too a bile duct that has been completely transected.
He has not realized the lower one transected bile duct. He has not still realized.
And after that,
At this phase.
watch. Yeah, he does something else after this.
He has realized. I think he would have if he had tried to cut it off there and tried to repair, he wouldn't have got the length of the CBD. So what his plan is, he's trying to repair the rent there at the close to the CHD, put a stent across, and then do a primary closure of the cut ends where he had transected.
Yeah.
So that was mainly because they wouldn't have got the length of the CBD to close it. Otherwise, he would have had to do a Roux-en-Y hepaticojejunostomy. That's why he has opted for suturing. But only thing is, he has done it through a T tube. Probably that end might not have reached that sutured area. That was my only critique here.
No, but also, Niranjan, when you have completely transected the bile duct and or put a clip across and transected it,
Yes, sir.
um,
That's what I said. He has
so
not
what
realized the
happens is, as you
lower end
know,
CBD. He has not realized
as
where
you
No, no.
know,
exactly.
As
the,
we go further, he opens up the lower end and he suture repairs the primary this thing.
yeah, correct. No,
Clearance.
but the problem is, Niranjan, the blood supply is 3 o'clock and 9 o'clock. So,
Yeah, yeah.
however good your repair is, it is going to worst case scenario, there will be leak. Best case scenario, there will be stricture.
Yeah, correct. That I don't deny. But that's what I don't know what surgeon he was. Basically, looking at him, the way he has suture repaired and all that, probably he was a GI surgeon who was probably doing the CBD repairs. But
Yeah.
only critique is the needle or the suture, this thing which he has used was too big. And definitely that common hepatic area where he sutures would have gone in for a stricture. Even if you would have bailed out, they show 15 days later they have done a cholangiogram and all that, it shows okay, but probably that will end up with a stricture there.
Definitely it will end up with a stricture. Yeah. Carry on, ma.
Because as a bailout procedure, I think since he was either a GI surgeon or the surgeon who was well versed with CBD repairs, to bail out, he has probably done the primary repair rather than going on and doing a. Ideally, this case would have required a Roux-en-Y common, this one, Roux-en-Y hepaticojejunostomy.
Jejunostomy, correct.
He wanted to get out of that trouble.
Sir, in case
For students, no license in the form of any amount of degrees, no license will guarantee you that you will not have complications for lab colis. Okay, so irrespective of whatever the degrees we have, it has to be a classical way of doing it. And we should be more careful when the gallbladder looks more innocent, like in this case.
Yes, sir.
Be careful when things are simple. After putting a first scope, looks like a good morning gallbladder. Be careful. Not that every good morning gallbladder will have problems, but we have to be careful. Like any other surgeries, give utmost care, come on straight, and then go ahead. We should not be casual for innocent looking gallbladder.
You're, as Sir said, you're only as good as your last procedure. You might have done thousands of them, but you start with what, this is the next procedure.
Classical,
Classical.
like 1, 2, 3, 4, 5. It has to come in the same order. You cannot have a 4 after 1 because we have an expertise. So after 1, it has to be 2 only, even after 100 years. Because safety is the priority. So 6 should come only after 5. And you should know what are the steps of 1, 2, 3, 4, 5. That's what we need to practice when we are a beginners. So just because we have practiced 10 years, don't select 6 after first. No, it has to be number 2 only.
Continue, ma.
Sir, in a current situation, hypothetically, if we realize that we have clipped or transacted CBD, what is the first thing we are supposed to do, sir?
The first thing to do is to call for help. Okay.
Yes.
And the thing is, as Niranjan has already outlined, there are very many ways of dealing with the problem. The one of the problem is if you have just clipped it, it is a bit more easier. If you have clipped and cut or transected the CBD, then it becomes a bigger problem. One is the caliber of the bile duct. See, most of the gallbladders that we are doing in symptomatic gallstones or acute cholecystitis, unless there is choledocholithiasis, cholangitis, and things like that, the bile duct will not be dilated. So, normal bile duct, 5 to 6 millimeters size, will be, will be difficult to, operate. So basically, what you have to do is to call for help as soon as you identify that you have either, injured the bile duct or you have transected the bile duct. As we keep saying, the one of the reasons why it happens is two things. One is non-recognition of the anatomy. Second thing is, while there is some bleeding which you think you are cauterizing using the cautery, and there is damage to the bile duct. So that can be damage immediately happening, or stricture of the CBD or say CHD at a later date. So as Asian Institute of Gastroenterology, what they say is every gallbladder, what you do is insert a gauze piece and keep it at the gallbladder bed. So in case there is any bleeding, don't try to immediately use the diathermy to catch it. Use the gauze piece to apply pressure. Wait for 3 minutes or so. Then sometimes what happens is if you have injured a major vessel, obviously the pressure won't help and bleeding happens. So then what you have to do is immediately call for help. But if in most situations the bleeding will stop or it will come down in intensity, gently remove your gauze piece and then see the point from where the bleeding is happening, and then you can use the diathermy or stitching, whatever you know, to control the bleed. So that is one thing. So a non-recognition of anatomy, and second is indiscreet use of diathermy to control bleeding. These are the two common causes for bile duct injury. So that is one thing. So these are two things you should remember. As Nikitha asked, if you identified bile duct injury, whether it is clipping of the bile duct or transection or partial transection, immediately stop the procedure, call for help. So the senior person who comes with you depends on his expertise whether he can repair the CBD at that stage. That there is still lots of debate going on whether primary repair of the CBD is better or delayed, or not completely delayed, that is in the next 4 weeks or so, or 2 to 4 weeks, and then beyond 4 weeks. So there is still a lot of debate as to which procedure is ideal. Everybody quotes advantages and disadvantages for each of them, but it again at that stage depends on not your expertise, because you already cut the CBD, so you don't do anything till you reach a certain level where you are experienced enough to repair it yourself. But otherwise, even if you are experienced, call a second person to help you, because you will have maybe junior residents who probably cannot help you as much as a senior experienced surgeon along with you. So even if you are an experienced surgeon having done 100 plus gallbladders, I would recommend that you get another person of similar or better experience than you to come and jointly manage the patient from then on, because then it makes, even apart from medical assurance that the person can give you and the help and confidence, even medico legally also it becomes easier for you to say I sought help as soon as we had a complication. So that is important. Niranjan and Professor Gurshantappa and Shrikant, please add to whatever I have just said. Hello?
There are Nikitha, no? Now she is presenting.
Yeah,
Yes.
Nikitha, yeah.
Yeah. Who else? Praveen also is there, Nikitha?
Yes, sir.
Yes, sir. Praveen is also there.
Okay. There are in biliary anatomy, there is an entity called a perception. So the one who does surgery, it depends on the perception of that person. What exactly is being wrong there? Okay, so there are a good number of studies showing that the wrongness is at the perception of the person who is doing the procedure. So if you have percepted or appreciated that there is some problem, or you have cut a CBD, you are half of the problems you have identified. Okay, that is what is the training that has to be done at the earliest. So if the perception is that yes, it has been transected, like Ravishankar mentioned, various options, that is a different topic. What are the options available when you have? So appreciation of complications on table is the priority for biliary surgeries. Once you have appreciated that there is something has gone wrong, then depending on that, the different issues, how to manage, whether it is dilated, not dilated, bleeding from the artery or bleeding from the hepatic artery. There are all different discussions. But perception and finding out on table is the priority in the training and during our professional experience for lab police. So if you have gone through that and identified 50% of the problems are solved, like I always, because complications are known. When the patient dies, if the complications are not identified at the earliest, if you get a training that yes, you could identify how the problems are solved, even by medico legally, because complications are known. Then I am managing the complications. Definitely, there are various options available. Please remember this.
Yes, sir.
Shrikant?
Nothing to add. First 100 cases, don't do independently. Always do under the supervision.
Niranjan?
Don't.
Sir, I think you mentioned everything. That is what. So if you are a beginner, call for help. That is the first thing. There are no egos here. And once, if depending on the expertise, you can either go for a primary repair, either through primary repair or through NY hepaticogestomy or choledochogestomy. If you don't have any help, safe to keep a drain, and then you contact the center which deals with this kind of problem. There is no harm in referring also. If you identified, as Guru Shantappa sir said, that is a half of your problems are solved if you identify. Just keep
Any
a drain
type
and
of primary repair here, it definitely leads to stricture because the CBD looks normal diameter, so in 100% it will go for stricture.
No, that is what, sir. It depends on the expertise and what is there.
Better not to do hepaticogestomy because next surgery will be far more difficult. Dilating the stricture also now very extremely difficult for intervention radiologist or open surgery.
Correct. Carry on the video.
One more, Ravishankar has mentioned, maybe if I'm right, almost 10 times, call for help. Yes, this definition can be fulfilled only in the institutes where people are available.
Yes, sir.
If you are a fully private practitioner and running a single-handed hospital or nursing home, and on a lighter side, theoretically, we speak from the stage as colleagues, colleaguography, call for help each other, don't comment each other. I'm sorry to mention this. In reality, most of the times it doesn't happen. I'm sorry to mention this. In reality, not very often it happens. Only in the institute, definitely you will have a help. But in private, many people talk, but you are the only person who need to give explanation, who need to face the problems and who need to manage and see that you speak to the relatives and manage the show nicely. Sorry to mention this, but it is a reality.
Yes, sir.
And realities are painful and bitter.
Yes, sir. So in that situation, Nikitha, if you identify a problem, as sir said, identification is half the battle. Then if you think that there is no help available at that stage, just put a drain, wash thoroughly, put a drain and come out. And then we can live to fight another day. You will then refer it to a center where bile duct injuries are dealt with. Okay?
Yes, sir.
Okay.
In the exam, this should be the answer. What Dr. Ravishankar mentioned last, no?
Yes, sir.
In the examination, if this is shown and the question is asked, this should be the answer. What he said, the last point.
Okay, sir.
Continue. The sad part of it, they're still trying to do it with the 3-port only. They have not managed to put another port at least to try and retract the liver. They are struggling. See, the liver is falling in, and still they are not. So this is another important thing. See, whenever there is bleeding, whenever these kind of things are there, even if you can manage them, please, don't hesitate to put another port which will help you to get better vision. See, whether it is open surgery or laparoscopic surgery, access and displaying the anatomy and proper, this one is very important. So previously they used to say big surgeons make big incisions. That may not always be true, but you see, whenever you call for help for a problem, what does the person come and do? He will extend the incision because he wants better access to the to the area and better demonstration of the whole thing. So that is why
Nikitha,
you should have put a port again.
Nikitha, what is that hanging and coming in the way? What is that hanging?
This portion, sir.
It is coming in the way of his procedure, no? Whatever he is trying
What is
to do a heroic. What is that hanging down?
What lobe, ma?
Caudate lobe of liver, sir.
Exactly. It is a caudate lobe invariably. Sometimes it is bigger in some people. So that is the one which hangs. And the decision of putting an extra port for a good exposure should be taken at the earliest. Putting an extra port is not a failure. So that decision has to be made at the earliest. We need extra port, even with a 4 port. If you are doing, we need an extra port for 2 reasons. One, the caudate lobe is big, which is hanging and coming in the way, so that you can retract by putting extra port. Second, you have a lot of fat lower down over the duodenum or a hepatico duodenal ligament. To retract that down, we need to have an extra port through the left hypochondrium. So these are the 2 areas we may need an extra port while doing laparoscopic cholecystectomies. Please remember, this question will be asked.
Okay.
Okay.
And this is what I was commenting. Look at the size of the needle and the thread.
Huge needle.
30 vicryl is too big for that too for such a small CBD. It's too big in this thing thread. You could have gone with either 4O or 5O, and the needle also, it's a huge needle.
Huge needle.
And the distance between the 2 segments is too long. It is more than 1.5 centimeter. If he opens the jaw of the instrument, it is more than that. So he is trying to approximate 2 entities which are far away.
Yes. And it is under tension also.
Under tension,
exactly.
Yeah.
And if the question is on mobilizing CBD, again the blood supply to CBD will be asked in the exam. What is a blood supply? What are those vessels called, and branches of what, and how many are there? It will be asked anatomically.
So Nikitha, what are the blood vessels? Where do they come?
3 o'clock and 9 o'clock position, sir.
Correct.
Names, I'm not sure, sir. Specific names, I'll get back on the names, sir.
Choledochal vessels. Anterior and posterior, medial and anterior, choledochal.
So that is why when there is transection, see it unlike other structures, blood supply cannot come from anywhere else, So that is why if you do a hepatico-jejunostomy, jejunum will provide the blood supply. But if you are transected and you are trying to repair it, almost as Srikanth said, almost certainly it will go for stricture.
But even if you do a CHD in this case, it might end up with a stricture because it is not a dilated biliary tree. So it is better that you try to attempt a primary closure if it is possible.
Primary closure you do, and then later you can do dilatation or whatever. And proximal dilatation will happen, then you can redo.
Yeah. That is what the literature also says. That is why there is no strict evidence that primary repair versus delayed repair, which still there, I think.
No,
the
primary repair is not recommended if the edges are friable. If it is healthy,
correct,
then
correct.
you can always try primary repair.
It looks like it is like a demonstration surgery for a T-tube repair of transected CBD.
This is not artificial intelligence created, no?
Illa.
for the teaching purpose.
As sir said, it looks like that.
Exactly. It looks like the way he has put nicely, he has put a T-tube.
So easily is put in.
Exactly.
But only thing is upper part, it was probably the left hepatic duct which was repaired, suture
Left
repaired.
hepatic duct.
It has got, this one has gone into right hepatic duct, probably, because that was not going in easily, the other end, upper end. So that might not drain properly and might end up with a stricture. And again, as sir was mentioning, see the gallbladder falling onto the operating area. And still they have not put an additional port there.
Sir, so just a question, sir. In case there is a transaction of CVD, in the meanwhile, while waiting for the help, should we go ahead and proceed with the cholecystectomy, sir, or we have to just wait?
No. Here, that gallbladder, you should not go ahead with and finish the cholecystectomy.
Don't do anything.
Mainly because it will help in traction. Here, they have not utilized that part. So gallbladder only, if you hold and push it up, that will give you enough traction there. The first thing, once they saw that golden bile, they should have done is put an extra port if they wanted to proceed with laparoscopic this thing only.
Yeah.
So that is the main thing why you don't proceed. And also, if you are not clear with the anatomy, if you had proceeded like what he was doing, trying to cauterize that area of the porta with the cautery, he would have damaged it even more further.
Correct.
Yes, sir.
So that is why.
Luckily for him, there was no portal vein. Otherwise, that would have also bled. So,
Yeah.
So other thing is, Nikitha, what all of you have to realize is the mindset. All of us, the moment a major catastrophe like that happens, we all become nervous and tense. So better to not do anything. First of all, for two reasons. One, the anatomy is not clear, which is why you have cut the bile duct. Two, you need the gallbladder for traction if you are planning to do a repair then and there. Three, you are not in a good state of mind. So don't add fuel to fire by trying to do something more. Just pack the area and call for help. That's the best thing you can do at that stage.
Luckily, the cautery has not injured the portal vein.
There. So if, as Guru Shantappa said, if you are alone somewhere and you think there is no help forthcoming, what you have to do is to don't try to take out the gallbladder. Just put a drain, wash the area, and come out. Then
Many a times people have just packed it, left it there, put a drain, explained and sent the patient to a higher center.
Correct.
That is not wrong. So rather than damaging more, you can stop it there and tell honestly that this is what has happened and this is what I will be doing it.
Not only referring, if it is in the same place, the best way is to accompany the patient and request the next senior person so that relatives will appreciate your efforts.
Yes.
If possible.
And other
Nikitha, if there is a bleeding along with this, what is that complication called? Along with this, there is a bleeding. There is a vessel injury and bleeding happens. Or worst, one more scenario is he will cauterize the duodenum, first part of the duodenum, and there is a rent in the duodenum also. So what are these called?
I don't think they've seen anything, sir, thankfully.
No. We should not be seeing in our lifetime. None of us should be seeing that.
It will be
but they should know.
There.
They should know. None of us would like to see such scenarios. It is like peptic ulcer disease. You have read peptic ulcer disease. The complications of peptic ulcer disease is perforation, obstruction. Is it not?
Yes, sir.
So if they coexist, can they coexist? There can be a perforation along with a stenosis.
Yes, sir.
Yeah, it can. So what are they called? If the two or three exist together in a given time, this can happen even in life also. In reality also it can happen. And there are instances where if one happens, invariably the second may happen. So be careful.
Triad, sir.
No,
kind.
concomitant. They are called concomitant complications. They exist together. It is a known entity.
Yeah. So,
Concomitant
Nikitha,
complication.
yeah. Nikitha, other thing is, as sir said, better to accompany the patient along with the, to the higher center. And also, I think to avoid any major this one, you have to somehow financially bear the, cost of the neck surgery and things like that, so that the problem is solved. It may still go for litigation, but at least you have shown your human side and made sure that the patient has been, managed well. After that, most of the time, if you do all these things, the chances are that they may not go for litigation. If they still do, then that's a different thing, but at least you could try and avoid that.
Finish the
Because
video.
this is the most litigious operation in the world.
Highest litigation in KMC.
Yeah.
Yeah, don't stop the video. If CBD is mobilized more than 1 centimeter during this procedure, the chances of ischemia is more, because the 0.5 centimeter of the edge of the transected CBD will have an impaired blood supply. So any mobilization beyond 1 centimeter will add to the ischemic injury to the edge of the CBD. You know where exactly should be kept the T-tube, Nikitha? When you do a open choledoco, this thing, T-tube exploration or T-tube insertion, what should be the site of the T? Hello?
Nikitha.
Where should be the T point of the T-tube when you put a T-tube in the CBD?
I didn't get the question, sir. Like lateral aspect or
Yeah, lateral. When you made a cut, no, when you open the CBD and you want to keep a T-tube there, where should be this T part of this, the one which comes out of the abdomen? In relation with the CBD, where should it be? Should be in the lower part. No suture should be below the T of the T-tube. It should sit on the tissue.
You followed, no?
Yes, sir. Yes, sir.
So, because when you remove the T-tube, that will help. If you have sutures beyond it, then it may not come out easily and you may still cause a tear of the CBD while you are removing. So that is the purpose of that question.
Nikitha, during this phase of surgery, you saw now, just now, the last part of it?
Yes.
If we, during this phase of surgery, if we see the bile again there, what is the inference?
Bile at a different point, sir.
Yeah,
when the GB
bile
is mobilized from the
dissecting the
bed.
gallbladder of the bed.
Gallbladder.
So what is the inference? Ducts of
Nikitha, pause it here.
Yes, paused, sir.
Ducts of
Duct
Luschka.
of Luschka.
So what is the significance of duct of Luschka?
Sir, they spontaneously resolve like.
But it will give you a lot of heartache because there is bile leak.
Yes, sir.
So if there is bile leak, you think the worst, that there's some injury to the bile duct or something like that. So that is why what sir said is very important. If you identify, most of the time you can't see those ducts. If you do, just clip them before you cut. So if you can't identify them, if many times you can't, the thing is, it will give you some sleepless nights because you don't know where the bile is coming from, and when you find out it's from ducts of Lashka, you will sleep well, but till then it will be a problem.
Hepatocystic duct. Hepatocystic duct.
Niranjan, you
This
wanted
is
to say something?
No. This is T-tube cholangiogram. So in this, I think there is still some leak going on, and that repaired area, that there is it is not continuous in that area. Yeah, that is probably area will go in for a stricture.
Defect.
Because as I was telling earlier, the T-tube end has gone into right hepatic duct, left hepatic duct where they have sutured. There is nothing going there.
Correct.
Already there is some dilatation intrahepatic.
Yeah.
I don't know whether you can see the pointer. And Nikitha?
Yes, sir.
There. Yeah. Go up. No, not up. I mean, up, above. Come down a little. Here.
Just
Here.
below that. That area.
Yeah.
Move it to the right side. A little bit. Yeah. There.
That is the problem.
The rent which had happened was just at that junction of this one common hepatic duct and starting of the right and left hepatic duct there. More to the left side.
As Gurushantapa sir said, if the distance is more than 1.5 centimeter, don't try to repair, because definitely it will go for stricture. As I said, the best case scenario will be stricture. Worst case scenario will be persistent bile leak, because the anastomosis won't heal. So if it goes for necrosis in the first week, then it will keep leaking bile. So that is a problem. So yeah, I think as Niranjan said, the early repair, if you are confident, is good. But I think if it is a partial tear, then you are well within your rights. Maybe nowadays, instead of putting the T-tube, you put a bile duct stent which is available, so you can get it from your cash.
You can get away with even in an infant feeding also if you don't have a stent.
If you don't have a stent, if you have a stent, that is ideal. So put a stent in and then repair over that. And if it is complete transaction, then there are many things. One is your expertise. Second is how dilated is the duct, and whether you because of the problem that we have already said before, especially if the two ends are slightly farther away and there is tension, not only just the tension but lack of blood supply. So in that case, you are better off doing a hepatico-jejunostomy. But if all other things are equal, then you can do a primary repair and hope that it will not go for stricture. If it does, then you can hopefully dilate it later and put a permanent or you may have to stent it several times before it becomes all right.
Sir, if it is a partial injury, is there any role for intra ERCP, sir, or it should be delayed?
You can do an intra PRCP if all that is all this thing is available.
You can do intra ERCP. You can also put a stent and repair the bile duct also. Both of them.
No. It is intracholangiogram, not ERCP. Cholangiogram. Through the rent, you have to put a tube and then put a dye and look for the imaging.
Both can be done. Even intra PRCP also is there.
But the problem is, Srikanth, the intra ERCP, the bile, the duct, the dye may just spill because there may not be continuity. So
and the position what required for ERCP may be lateral or prone position may be difficult because there is a rent scene. So put a catheter there and put a dye and see the imaging. That's all per operative cholangiogram.
No, she was asking for about treatment, sir. If it is just a partial tear, if the posterior wall is intact, whether intra PRCP can be done.
No, it is an operative cholangiogram and put a stent and do a partial repair. That's all.
Stent through the laparoscopic.
Yeah, through laparoscopy only. If the rent is seen, why you want ERCP?
Through the hole.
If rent is seen already, through the hole. Put a stent, put a clip there, a temporary clip. Put a dye, see the imaging, and then take out and put a primary stent inside and a primary repair.
Okay.
That is an ideal treatment for a partial repair, partial tear with the posterior wall intact, or a anterior-posterior wall intact, only there is a lateral rent. That is ideal treatment. That is accepted treatment for operative cholangiogram and primary repair. That should be your answer.
Okay.
So the video is complete now. Now you stop sharing. I will just share and just give you there is the safe cholecystectomy. I presented that in the
One more Ravishankar, because she has shown us the T-tube. What should be the lower limit of the T-tube, Nikitha? Lower end of the T-tube, where should it stop? And why?
Lower end of the
In the
T-tube.
CBD. In the CBD, lower end, no T part of the lower one. Upper one will go to the hepatic ducts. So where should be ideally? Where should it stop? You did not understand?
I did not understand it, sir.
Go to
No,
the picture.
T part of the T-tube, no?
Yes, sir.
It is inside the CBD. Upper end is into the hepatic ducts.
Yes, sir.
Lower end is in the common bile duct. So where should it stop? Lower end. Should it go into the duodenum?
It shouldn't go into the duodenum.
Why?
At the time of retrieval, will it?
No.
Blocks
should
the
not-
pancreatic duct.
Yeah, it should not obstruct the pancreatic duct. Otherwise, this may induce acute pancreatitis. So it should short off pancreatic duct opening or a formation of a common channel between the CBD and the pancreatic duct. So it has to be above the ampulla of Vater.
Okay.
To avoid development of acute pancreatitis. It is a known entity. Okay. Fine. ರವಿಶಂಕರ್ ನಿಮ್ದು ವಿಡಿಯೋ ಇದೆನಾ ಒಂದು?
ಇಲ್ಲ ಅದು I will I think I will send it to all of you. Just the one slide which I wanted to show the do's and don'ts of safe laparoscopic cholecystectomy. I think but I'll share it with you guys because it's already 10 o'clock. I think we have discussed a lot of these things. So let us not.
But scary video. I am really I don't want to see such scene on while doing laparoscopy.
Correct.
Pray that it doesn't happen to us.
Yeah, we should pray.
So I think
1 year of your life is gone.
Correct.
No, but I think he was able to manage it and get away with it. Probably
This is temporary reprieve ಅಷ್ಟೇ ಇದು.
Whatever it is, but if he is managed to escape the acute trouble.
ಅದೇ ಹೇಳಿದ್ದು gone out of the crisis ಅಷ್ಟೇ.
So this, can you see this now? Is the images visible?
Yes, sir.
So the critical view of safety. So you can see the safety line and Ruvier sulcus there. Can you see this one? My pointer. Are you seeing my
Yes,
pointer or not?
Yes, sir.
It is seen.
Yeah.
Make it a slideshow, Ravishankar. Make it slideshow.
Yeah.
Slideshow.
Okay.
Yeah, it is seen now.
So the safety line, can you see? It is very close to the gallbladder, and so basically you follow that principle. Again, this is a same picture. Just to show you the posterior dissection and anterior dissection both. So now you can see that this is the bile duct there, two structures going into the gallbladder, and again the same view posteriorly. You can see that structure going, and you have a clear view of the liver beyond the dissection, and then here now you are safe to doing it. And as you see now, again gallbladder, cystic artery, cystic duct, CBD there. So with that, you can safely clip and cut. See again, same this one. both two views. So here you can see the CBD there, clips put both to the artery and the thing. You can use the, the help of indocyanine green and infrared. If you have the facility, you can see the bile duct and cystic duct, everything demonstrated well. So
In
it's lighting
future,
up
indocyanine green will become routine.
so you can see that, use this if you have the facility. So, these are complications anyway, you know all this, do's and don'ts. So, for example, I'll just read it out. First of all, your indication should be watertight. Don't compromise on indications. Proper preoperative evaluation again, safe entry into abdomen, optimal port placement, patience in dissection, achieve CVS at all costs, minimal use of energy sources, good hemostasis throughout, apply clip suture securely, think before clip application, seek help or second opinion on table if you are not sure. Don't operate outside the standard indication, use umbilicus as port of entry in prayer operated patients because you may cause injury to the bowel. Again, you convert a standard operation into a difficult operation. Use excessive energy source near vital structures. Use energy blindly to control bleeding. Lose patience if dissection is tough. Clip vital structure before ensuring that what we are clipping, and ask for a large clip still if you are sure, don't ask for a large clip, because if you are asking for a large clip, that means you are, probably going to clip something that shouldn't be clipped. And excessive number of clips, you should not use more than 4 or 6 clips. 6 including sometimes the clip will not apply properly or it will fall into the abdomen. So beyond one clip, the dispenser, you should be really careful why you are using more than that, and hesitate to convert for complications or lack of progress, frozen callos, anatomic variations if you are not sure, and take on complicated cases in early in your career without senior support. So these are all my, do's and don'ts. I think a lot of people appreciated this slide, so I thought I'll put it up. Okay. So any questions and final comments from Srikanth, Niranjan, and Gurshanta Pasar, and one of the students.
No questions, sir.
No questions? Gurshanta Pasar?
Yeah, she don't have any questions because she has seen that beautiful video, and probably, or she must have not seen many. And he has mentioned a beautiful slide, do's and don'ts. It is only the number, and if we can learn the classical way of doing it, probably you will not come across complications.
Yes, sir.
What is more scary is bleeding rather than a bile injury, because we get scared when because of the magnification.
Yes.
So, and once there is a complication of bleeding, invariably that will be followed by a biliary injury if you don't know how to tackle bleeding.
Correct. Yes,
Because
sir.
in the bargain, to control the bleeding, we'll end up with a biliary complications, which are more serious.
Yes, sir.
Okay, so if we can learn how to manage a bleeding complication, because bleeding is going to happen more often than a biliary injuries in lap chole.
Yes, sir.
That is, if the question is what is the commonest complication, it is a bleeding, not the biliary injuries.
Injury. Correct.
Okay, because we demonstrate biliary anatomy most often. So if you know how to manage bleeding complication, in the bargain, you will be avoiding biliary complications. So like mentioned, use a gauze piece, weight, demonstrate anatomy, and then avoid using diathermy. Try to either learn putting a ligation or a clip and manage it nicely so that you can avoid biliary injuries. If
Yes,
biliary injury is the complication, best way is to abandon the procedure, keep a pack there or drain, and shift the patient and manage accordingly with the help of your other colleagues,
yes.
other than doing a heroic intervention. Okay, and third is we should not get scared. Complications are known. It is an identification where somebody fails and land up with legal problems.
Yes, sir.
Okay, this is the way we should Okay.
Thank you, sir.
Fine.
Srikanth,
Nothing to add. No, very good discussion. You have covered everything.
Niranjan.
Good discussion, sir. Nothing else. Thank you.
So I think this is a very novel.
First time I am seeing a left hepatic duct being sutured.
So I think the lessons were many. One is the initial thing, and later after the injury was recognized, I think it was not handled in the most appropriate way. So that don't stand on your this one ego and say I can handle anything. And I think that was actually the crux of the problem in this case. You should have because the complete transaction was there and the distance between the two ends was large, you should not have attempted primary repair in that situation. So those are the multiple lessons that we learned. It was a very good demonstration of how not to do things. So sometimes that is also required. So if there are no questions, we'll stop the class. And I thank sincerely Niranjan, Srikanth and Professor Gurshantappa for their very, very valuable inputs. Thank you. Good night.
Thank you. Good night.